pleased to speak to you today and learn about these initiatives. I am a professor of chronic disease epidemiology, so I work with population health data and biobanks, electronic health records, trying to address, trying to do research related to multimorbidity. As you will realize, because this field requires so many disciplines together, my own research is limited to sort of analyzing large-scale data, whereas here we need a lot of other layers of research that come after that in order to be able to create impact and to translate those findings. So I'll start with that, just to mention that I'm based at Imperial, the School of Public Health, and I also have an affiliation in a Greek Research Institute in Athens. And in those both, I mainly work on chronic diseases, mainly cardiovascular disease, neurodegenerative diseases, and some cancers, and you will soon realize that these are all the diseases that one of the main component of multimorbidities, and that's how I got interested in this field as well. So if I start with the usual sort of key concepts and definitions, the patients, from a patient's perspective, they don't enjoy many times the word of multimorbidity. So we tend to use it as to substitute, if you like, the multimorbidity with the multiple long-term conditions or multiple coexisting conditions. We usually define it as more than two, but you've heard that the definitions vary, and one of the problems is that we don't have a good sort of harmonized terminology in multimorbidity. And I have the chronic in brackets here because usually for us chronic condition is non-communicable diseases. But more and more the infectious diseases come into play, because not only we have chronic infections, but we have chronic, if you like, results of infections, which are often related to multimorbidity. We sort of saw this from the COVID-19 pandemic, but we also know it from many others, especially in cancers, but there is sort of a lot of emerging interest in this and the multimorbidity related to this exposure. So even the sort of chronic, if you like, if we translate it to the sense of communicable, non-communicable diseases may not be accurate here. Now, the interest that is accumulating in the literature has to do with the fact that it's rapidly increasing in populations. And this is partly because of the fact that the populations are aging, so they sort of, and because multimorbidity is associated with age, we have this increasing prevalence, but at the same time, we also have increasing multimorbidity in younger populations, partly because we are moving the diagnosis of some diseases earlier, and we are getting better at identifying diagnosis. But also because of some diseases that may sort of develop or increase their incidence in these age ranges. The multimorbidity is not just a coexistence of two conditions. Things would be easier if that was only the problem. The fact is that these conditions interact, and they interact biologically. So the fact that they two coexist may end up with different progression of the disease or with different sort of symptoms, but they also interact socially. The fact that someone is has multiple conditions interacts with how they access care, what the type of care they get, the sort of medication. So it's not just the fact that they happen together, it's their interaction that is of interest here. And it's interest mainly because of the health systems, where until now we have sort of the silos and the single condition silos that we sort of, the care is fragmented into different disciplines. We don't have integrated guidelines on what happens when we are presented with patients that have multiple conditions, and that has an impact on the quality of life of individuals, on the type of care they receive, and risk related to polypharmacy that we haven't studied or examined. Now, at the same time, we are at a crossroad, at an unprecedented time, if you like, in population health research, because we are having access to unprecedented resources. For example, this is on the left, there is an example of the UK Biobank, but we also have many other similar European biobanks where we have population-based cohorts. They are not disease-based cohorts. They are population-based collections of phenotypes of individuals with their omics profile, genetics, and many other omics layers, with very deep phenotyping on their medical history, on their lifestyle exposures, with imaging on a very large number of 60, 70,000 people, for example, having brain scans, MRI scans, whole body scans, and digital assessments of, for example, their physical activity with continuous measurements over 7 days with accelerometer. So a lot of measurements that we weren't able to have before. At the same time, these and other resources are linked to well-curated electronic health data, either primary care data or hospital episode statistics, national mortality data, and national disease registries. And not only data that linkage to this type of medical data, but also linkages to environmental exposures or to other type of data that are at the national level. And of course, we have novel methodologies that are not limited to artificial intelligence, but include artificial intelligence on how to bring this data together and make inferences with this data. So suddenly, we are well equipped to address multimorbidity, because then we don't have, if you like, data in silos on single diseases, but we have very deep phenotyping, which is very broad, also in terms of environmental, lifestyle, biological measurements, but also in terms of disease follow-up. What questions can we address now with this data that we have? One question that is very much of interest to us is, what are the most common disease clusters and trajectories? I know many of us have tried to do this, but this is still something that is of interest, because we haven't tackled this yet. I mean, we know some very common constellation of disorders, but we haven't done a lot beyond that. So we know, for example, the cardiometabolic renal sort of clustering, but there is much more into that. And we are interested in that for multiple reasons. First of all, because knowing this, the fact that some diseases occur most often than you would expect by chance in the same individuals can offer biological insights. Why do they occur together? What do they share in order to occur together? At the same time, the fact that they occur together and there is a trajectory can help us identify trajectories in individuals. So someone that has a trajectory, we are able to sort of continue their trajectory, their line of trajectory, and then without any interest in causality, our interest is there to predict the next events, to find the trajectory, to make individual digital consultations, if you like, based on this sequence of events. Then, with this information, what we want to address is how can we design interventions that work in this real-world complexity, interventions that address this population that is suffers from multimorbidity. For example, a population that is not currently represented in clinical trials, which haven't included people with multiple long-term conditions by definition. And how then do we incorporate the patient priorities and the lived experience in this design? Because this is very important here. Now, with this setting the scene, I will sort of present some of our recent works on this, setting the grounds of things that we could do with to address this issue. So the first example will be a clustering example, what we can learn from clustering and how we can work on it nowadays. So traditionally, a lot of studies have looked at clustering, that sort of diseases that happen together cross-sectionally. We have a population and we see how diseases are grouped, are clustering in individuals. But what we wanted to do differently in this study that has been recently published is to look at the longitudinal clustering of events. So the fact that throughout the lifetime things can happen, and the longitudinal cluster has similarity among patients. So patients that develop heart attack may later on develop dementia, for example. We used primary care data from the UK. This is CPRD. This is large primary care data set of millions of people that are linked also to secondary care data set to do that. So we had this rich longitudinal data set with a lot of codes from primary care, codes from medications, codes from events in the hospital admission, etc. And to do the trajectories, we used a large language model. So currently the model that ChatGPT may be using to make prediction of the next word, in a way we use that to predict the next medical code or to fill in the missing medical code of people, and to address like this the complexity of our data. We wanted our main aim here, you could do this to predict events or to associate mortality. Here particularly we did it to group people together with similar trajectories and sort of come up with some interpretable clusters for precision medicine application. Now, these are a little bit the methods that I would like to sort of briefly mention in the limited time we have, and this is work from a research fellow in my team, Alex Smith. Sort of imagine we had these different codes, sort of hospital records, symptoms and diagnostic tests, GP records, medications, and we can use the LLM models to make a sequence, an embedding of each individual of those events, have additional layers of gender, age, and the visit and the calendar year. So we created these longitudinal sequences of patients, and we use the HR, the Berta model, in order to create these female and male specific embeddings. And then we grouped the appendix, we clustered the embeddings with a clustering pipeline. Here you can use quite different ways of method, and that resulted to individuals that cluster together. In the next slide, I have an example of that clustering. So these columns here are different clusters, and these are the diseases, for example, that are in its cluster. The higher the red color, the most prevalent the disease is, the more prevalent the disease is, and the plus or the minus is where the disease is significantly more prevalent or significantly less prevalent in this cluster. Now, depending on the diseases that were in these clusters, we named them. They came up with four main enrichments. One was a mental health cluster. So diseases, clusters of individuals longitudinally that they had a number of mental health disorders. The other was a cardiometabolic cluster, which often coincided with other diseases like COPD, chronic kidney disease, dementia, respiratory clusters, and mixed clusters. So you can, we describe at the paper each cluster specifically sort of what type of different cardiovascular diseases coincide with different other diseases here, etc. So that there is a lot of discussion there, but that allows us to find some sort of trajectories of individuals and some disease that happened together that we wanted to look more specifically. But also now we are doing work to see whether what the mortality associated with its cluster in order to be able to have some impact and translational potential on, you know, how do we translate these clusters, which by the way, they were different in males and females. But, there is no time to present that today. Now, so we find these clusters. Why are we interested in them? I sort of briefly touched upon it, but one reason why we are interested in them is that because we can have some biological inferences based on that. So one scenario could be that disease A is causal to disease B. That's why they happen together. So, for example, diabetes may cause, not may, it causes coronary heart disease, for example. So and with that, we know that if we treat one condition, we treat both of them. So we can have common treatments and avoid multimorbidity. That's quite important. Other scenario can happen. For example, disease A, you get a treatment for disease A, and then you get a side effect of this treatment and you get disease B. So there is a mediating pathway there that is important for us to understand and intervene. It could be not a treatment, it could be something else. And then those two diseases may have a common risk factor. And if they have a common risk factor, again, by treating that risk factor or changing this risk factor, if it's a lifestyle intervention, we can have multiple beneficial outcomes. So disease co-occurrence can give us important clues to disease mechanisms that are important in this setting. We know some common biological mechanisms like chronic inflammation, oxidative stress, pathways relating to aging that seem to underlie multiple conditions, but we have a lot more to learn there and go deeper into the specific aging, if you like, pathways. We can learn common risk factors, whether genetic or social or environmental or lifestyle. And these shared pathways can offer shared solution, can offer interventions that target multiple conditions simultaneously, can offer better preventing strategies and better treatment design, and also importantly, opportunities for drug repurposing. So treatment for one condition, for example, say we had metformin, for example, that is treating diabetes. It could be repurposed to treat Alzheimer's disease or dementia if we make a causal link between diabetes and dementia and Alzheimer's disease. What else can we do with this data? Beyond causal inference, we are interested in prediction, and these two are very different scenarios. In prediction, we don't care at all whether there is a causal association. What we want is to predict. And here, having a lot, sorry, this is not my prediction slide. Here is going deeper into mechanisms, my apologies, with multi-omics data. So we establish an association between diabetes, say, and cardiovascular disease, or for example, here hypertension and cardiovascular disease, which we know hypertension is a major contributor to multimorbidity. And we know the established links with cardiovascular disease. In this recent work that we have done is that we used proteomics data to find the common proteins that are associated with blood pressure and with cardiovascular disease through blood pressure, in order to be able to find targets that will improve both outcomes. And that's an example with proteomics data, but having a lot of omics data can help us look more on these molecular pathways. Here we use the UK Biobank and large-scale GWAS data that is available on with summary level data from large GWAS studies on proteomics, blood pressure, and coronary heart disease. And we did in parallel both a Mendelian randomization approach that gives genetic evidence that there is a causal association, as well as an observational approach looking at levels of protein with levels of blood pressure and with coronary heart disease and stroke, and found a set of proteins that can affect both blood pressure and coronary artery disease, both blood pressure and stroke. And did some downstream analysis to sort of go deeper into the biological mechanisms that affect both, and mediation analysis to see how much of the effect of one particular protein towards CAD is mediated through blood pressure. And that can help us infer how much, if we treat one particular protein, how much of the effect of blood pressure may be explained and how much we would gain. And proteins, particularly here, are very attractive as they are often the target of pharmacological interventions. Now, in terms of prediction, what I tried to do before is that often we don't want to have a causal association, we want to predict, and having this large omics data can help us make better prediction. Because, for example, for cardiovascular disease, we know a lot of risk factors, but for many other chronic diseases, we don't have sort of strong clinical risk factors. Here again, we used the omics data, almost 3,000 proteins measured in UK Biobank, and then a deep learning approach here, as well as an elastic net approach. So we used one more complicated deep learning, machine learning approach, another more traditional one to predict 27 diseases. The reason I have it here that is relevant to multimorbidity is that if we looked at the proteins that contribute to the prediction of different diseases, here in blue, you see the amount of proteins that are shared between diseases. So we have a number of different diseases and a common set of proteins that predict their development. So one could think that we can use this data to predict multiple conditions with the same prediction models, and that could offer a lot of opportunities for identifying early multimorbidity or sort of informing people that are the risk of developing multiple conditions with this data. So there is a number of unmet needs, but also innovative innovation opportunities here with these examples. One observation is that we need to have this multimodal integration of different data. I talked a lot about omics today, which can be integrated, and the omics we discussed about a lot here, genetics and omics, but there is clinical imaging, lifestyle, and social data available that can be integrated. The more data we start using, and the more data we have access to, the challenges emerge, particularly regarding how to merge this data. How are we going to be able to sort of combine data from different countries or different sources? And here we need to think more about federated learning approaches. how we can combine this data set, especially since we are moving into more secure environments where data would be stored in trusted TREs, trusted research environments, or particular cloud systems that we are not able to harmonize it and integrate it as we used to do particularly. And then that helps us move towards integrated care pathways, digital twins, predictive risk profiling, and precision prevention. We can use similar approaches to study polypharmacy, so to use sort of similar trajectories of medicinal products, or how to have an optimization of these polypharmacies with sort of AI-based or similar methodologies. A lot of the data I talk today is real-world data, and we want this the next step to use real-world test beds, to use adaptive evaluations, and then not to forget the patient perspective in this. Particularly for multimorbidity, the patient experience is uniquely valuable, and co-design tools and patient-facing apps should be something we should be thinking of. So finally, what to look for? It is definitely an area where we need multiple disciplines. It's the multi is in the definition of what we are studying. So it's multiple disciplines and different sectors that need to come together to tackle these problems. We need first we have the usual garbage in and garbage out. We need to take care of the data. We need good data in order to answer these questions, and we need multimodal data and data that we can integrate and harmonize. So think a lot about federated, privacy-preserving analytics, how we are going to bring things together from different layers, different countries, different sectors. And then again, real-world applicability. The test beds, the living labs, digital twins, use digital medicine in order to sort of look the application of the intervention or the model or how we are going to use the data in the first step, and then how we are going to test its applicability and its implementation, look at the cost effectiveness of solutions, where they can be scalable and sustainable, and whether they can be adapted across a wide range of countries, or that's something very unique to a particular population. Of course, keep in mind the ethics, the equity, and the patient-centeredness, and this approach that we again touched upon this before, and think about to have innovation with impact. So we want solution addresses, high need, high burden, multimorbidity clusters, in order to have, the anticipated impact. Yes, and I'll finish around there, and I'm happy to discuss questions. I hope that was helpful for you.